Let's talk about breast cancer patients. All of us have breasts. While breast cancer is more common in women, I do see men, although their risk is 1%. The breast is comprised of tubes or ducts and milk glands or lobules. 85% of all cancers begin in the ducts and 15% in the lobules. Why is this important? Lobular cancers are felt to have an element of bilaterality, which means now or at some point in the future, the cancer is likely to be in the other breast, and that is one reason why patients will choose to have a bilateral mastectomy. If the cancer begins in the duct but is not broken through the duct, we call that DCIS, or ductal cancer in situ, or in place. If it starts in the lobules but is not broken through the lobules, we call that LCIS, or lobular cancer in situ. These are really considered precancers in that they have not broken through the duct or the lobule, and they have not spread to the lymph nodes. If the cancer has broken through the duct or lobule but not necessarily spread elsewhere in the body, we call this invasive mammary cancer of no special type, or IMC-NOS. Patients will actually see this on their pathology report. The next thing you will see on your path is the grade. Many people come to me and are terrified. When I ask them why, they say, well, I have stage 3. I ask them how they know this, and they say, it says so on my pathology. So this is the misconception. If you have had a biopsy, the only thing you will know is that you have breast cancer and the grade. Stage is only determined after surgery, that is lumpectomy, mastectomy, or from a sentinel lymph node biopsy. All that information comes in bits and pieces. Grade is an eyeball exam by the pathologist of your breast cancer biopsy. They get the grade by comparing your cancer cell to that of a normal breast cell. If it looks very similar, it is grade 1. Less similar, grade 2. Totally dissimilar, grade 3. It is as simple as that. Although this information is taken into consideration, it is really the stage that dictates treatment and prognosis, and this will only be known 2 to 3 weeks after your surgery. For a breast cancer cell to spread outside of the breast to the rest of the body, it has to go into the arterial system. This is extremely difficult for cancer cells. It is analogous to me standing at the top of Niagara Falls and jumping over headfirst. I would likely die. But let's say I was a special cancer cell and I made it over the falls and lived, and went into a quiet little stream and decided to live there. The cancer cell would start to divide into 2, and then 4, and then 8, on and on for about 30 dividings, maybe over 30 days each, so 900 days later, or about 3 years, that cancer cell may be big enough to be detected by modern technology. That is why treatment for breast cancer normally includes some form of local treatment, lumpectomy, mastectomy, and radiation, and some form of systemic treatment, chemotherapy given intravenously or oral. The systemic treatment is to get at those special cells that may have had a chance to spread. Whether you have the local treatment first and then the systemic, or in reverse order, the systemic to shrink a tumor, and then local makes no difference. You will be offered both. And that is Breast Cancer 101.